Gotta have some fun with this, okay? All right, so let's go back to the trach. How many of you have ever cared for a patient with a trach? Yes, okay, and so do you know why they had the trach by chance, Maria?
One of them had a car accident and he was paralyzed.
Okay, and what about you? About the same thing? Okay, so with your patient, I mean, at that time, was it during level 1 or was it just at another time?
Mine was like
Outside of school? Okay, so you just at least got to see a patient who had a trach and then maybe kind of assisted in taking care of them, but not necessarily doing anything with the trach. All right, well, that's what we're gonna learn about today. You've already done the trach, suction and care practice, and checkoffs are today. So let's go into some trach. All right, so I'm gonna go over some terms with you. Most of these you will probably already know just because we talked about it last week in the lab, okay? All right, so what is a trach? I mean, we'll say trach because it's just a lot easier. And so if you look at it, it's surgically created stoma to bypass this breathing up here that all of us in here breathe, yes? Okay, all right, so some reasons is maybe because, they can't breathe on their own, they've got a lot of secretion, so there's gonna be multiple reasons why, and I'm gonna ask you in a little bit, but I'm just kind of going over. Make sure if you have a patient who's had a trach, now if they'd had it for years, then it's gonna be permanent. But if you happen to be like in an acute care setting and they have a brand new trach, always see if you can find out, is this temporary or is it permanent, okay? Because not everybody with a trach is gonna have it permanently, okay? An example I can give you would be maybe somebody who has laryngeal cancer, okay? And they may be getting radiation treatment. And if you think about with that radiation treatment in this area, why would they end up putting a trach in somebody? Take some wild guesses. Come on. Anyone?
There's like obstruction of the voice box.
Well, no, not that. What could the radiation treatment do to this area? Okay, so they may want to put in a trach. So when they're doing that and they're having the radiation treatment, what they're going to also do is probably have like a feeding tube for a certain amount of time until the radiation treatments are done. And then if the patient can, they'll reverse everything. They'll take out the feeding tube, they'll reverse the trach. So it just depends. Sometimes it might just be emergency situation and then they can reverse it. So always ask and see. Even in some of the rehabs, we've actually watched them take out the trach in the long-term acute care setting and even in rehab. So, and they've had it actually for a while, but they've gotten to the point that the doctor or the healthcare provider thinks that they don't need it anymore. So always ask and see, okay? All right, so just to kind of show you a picture, you can kind of see where it would be about located. It just kind of depends. Okay, some terms, intercannula, some people call it a sleeve. Y'all all know that, right? That's what you have to take out today and do that fun cleaning. A phalange, or what's called a neck plate. That's the part that just kind of goes across over here, just the neck plate of it, okay? And then the obturator, all right? And the obturator does what? So it's used as a guide to put the whole trach in, correct? All right. So the neck plate is where you're gonna do the ties or the Velcro or whatever just to secure it, all right? I'm gonna kind of keep on going, all right? And if you have questions, let me know. So here's just another picture where you can see, all right? So you can see the neck plate right here, all right? You can see the obturator, the inner cannula, and then this one has actually got a cuff, and we're gonna talk about some cuffs here in just a little bit, okay? Oh, and there's your inner cannula on the other side. Okay, so let's kind of talk about some cuffs, all right? Your book talks about 2 different kinds of cuffs. You've got the cuff that's called a cuff and pilot balloon, and this is actually what the respiratory therapy, unless you are trained, I let RT take care of this. They will go in there and inflate and deflate, okay? And when I say inflate and deflate, let me just make sure that y'all can understand what I mean. Let's see, is this gonna come on? Oh yeah, okay. So do you see how you've got the cuff? And then remember I told you you're gonna have a little pigtail, okay? So just so you can see what it looks like, I've got a little syringe. They would come in and attach, and let's see if we can make it inflate. Did you see that? All right, so they're gonna go and see when this is inflated, this, turn on the side, looks like it's inflated, right? And then when they would deflate it, see the same thing, okay? With these is you have to go in there usually every 8 hours, but check the policy, and RT is usually the ones that do this, and they would go in to inflate and deflate, okay? Why do you think that is? Why do you think it's important to inflate and deflate periodically? Anyone? I'm sorry?
Scar tissue?
Yes, and what do you mean by that, Meredith?
Like it might start to close around it, or
No, you were close a while ago. It's not that it closes around it, but when we're inflating that cuff, what is it doing to the tissue around that area? Okay, but it's also putting what on it? Pressure on it, okay? And if you keep that pressure on there over time, what's going to happen? You're going to get what? Okay, exactly. It's just like any pressure anywhere. If you all sat in here for 12 hours on your bottom, yes, are you going to start getting some pressure? Yes. So it's the same thing. Anything that puts pressure can cause skin breakdown, even on the inside, okay? So I want you to remember that. Now, with the foamed cuff, it's different. They don't go and inflate and deflate. It actually is when the patient inhales, then it inflates on its own, and then it goes down as well. Now, that's something that's just a little bit different. Okay, so I just want you to know that there are, in the book, it talks about the two different kinds, and we do not go in there and inflate it with air, not with the foamed, okay? So all I want you to know is that you may not know what kind of cuff it is. That's okay. I just want you to know my patient has a cuff, and is it inflated or deflated? And that's part of your documentation. You can talk to respiratory therapy and you can say, you know, do you know what kind this is? Because I don't know, I wasn't there when they put it in and I can't find it anywhere in the chart. But you need to make sure that you're going in there and seeing that it's inflated or it's deflated and if they have a cuff or not, okay? What are some reasons somebody would have a cuff? Okay, a lot of times they'll have it if they think that they're at risk for aspiration. Okay, so that'll be one right there. I used to see it used for the radiation therapy, but not as much anymore. So it's nice to know sometimes, well, why would my patient have a cuff? So that a lot of times it's going to be because that they have a risk for aspiration. Okay? All right, couple more terms. Ties, cotton ties, or Velcro. You're going to really see the Velcro. We're having you do those fun little shoestring ties in the lab because we figured if you can do it the hard way, you can do it the easy way, correct? All right. Now, a trach button, that's something that you may see. They're a little bit different than what we're going to talk about the speaking valves later on, but a trach button is what they would put on it that completely cover if they were wanting to try and wean the patient off of the trach, okay? They also have something I'll talk to you in a little bit. It's called a trach plug, and it's a little bit different. But for right now, I just want you to know they may end up putting a button on there. But if they're going to put a button on somebody or a trach plug, let me go ahead and go to my next one. Well, actually, yeah, this one. What are some things that you think that you're going to want to, let's say that the doctor orders or respiratory comes in and they put a trach button or a trach plug on a patient. What are you going to want to make sure that you're assessing? Oxygen sats and what else? Just in general. Okay, that's fine, but in general, guys. Okay. Yes, let's make sure that they can breathe, okay? What if they go and put that on there and they seem okay for a little bit and all of a sudden now they're having a hard time breathing? Remember, at the beginning when you have a trach, all of this is bypassed. So if we're gonna go and plug this up, they better be able to breathe up here. And if they can't, that's the same thing as me coming and putting something over you and you can't breathe. What's the difference, right? So make sure that they can breathe. That's the main thing with the trach button or the plug that I want you to make sure that you continue to monitor. Just because they put it on at the beginning and the patient seems fine, that's great, but you need to kind of continuously be checking on them. How are you doing? Let me know if you have any trouble, breathing or anything like that, because we're trying to see before they actually take the trach out, let's try to do this and let's make sure that they can breathe on their own, right? Okay. Another term I want you to know, it's called a fenestration, and that is when the whole outer cannula will have a hole in it, and then usually the inner cannula will not, okay? But what do you think that this is for? Well, I wrote it down up there. It says right there, what is it for? And how, okay, so then how does that work? Tell me how you think that works. Okay, let's take a step back. If somebody has a non-fenestrated, which means that they would not have a hole in the cannula, the whole outer cannula, the patient cannot speak. Why can't the patient speak? But why?
There's no opening for the vocal cords, they run together.
You're right there, but where are my vocal cords in comparison to the trach? They're what?
So a non-fenestrated one would be bringing the air down
No, not necessarily. Hang on. Somebody was right there. Where are the vocal cords in comparison to the trach? Above it, correct? All right, so when I have a trach and all of my air is coming out this way, no air is going up to go to my vocal cords. See what I mean? All right, so if a patient were to have a fenestrated, okay, and you take out the inner cannula, especially, and this is where we're going to talk about the plug in just a minute, then it allows them to speak. Now, they could go and cover it and say something, and that's, another way that they can, but that's not always feasible, right? So if a patient were to have a fenestrated, what they're going to end up doing is they're going to use a plug, and they're going to go and put the plug in, and then it's going to allow them, they usually they have to take out the inner cannula first, unless the inner cannula had a fenestration. But most of them don't, and do you know why? So this is my whole cannula. Okay, now this one isn't, and it would have a hole, which means it's fenestrated. But my inner cannula does not have a hole. Why do you think that is? What about suctioning? What could happen? If this had, and I'm not saying that they don't, but most of the time they don't, the inner cannula is non-fenestrated. Because when you suction, if it was, what would happen? You could damage. So think about that. So let's just say I took out the inner cannula, okay? And let's say I decided to go and suction. Then that inner cannula, or the catheter, can go through, and can you think about what I'm going to be suctioning? The tissue? That's not what I want to do, right? Okay, so if the patient were to have a fenestrated trach, and they're trying to, a weaning period, they're going to take out the inner cannula. If it's cuffed, it has to be deflated. Why does it have to be deflated? If it's blown up, nothing's going to go, what's going to happen around it? No, so they can speak. Okay, so if I were to have an inner cannula that is fenestrated, it has the hole, I take out the outer cannula, okay? If I go get my plug and I put it there and it's still, the balloon, or the cuff is still blown up, it's not gonna allow for a lot of air to go up through here so I can speak and go through my vocal cords, correct? So you have to make sure that it's deflated. And they'll put the plug on it and they'll put it on for a certain amount of time, kind of see how the patient does, all right? And then later on, they may go back and then unplug it, put the inner cannula back in, and then that's whenever, if you needed to, you'd have to inflate the cuff again. Does that make sense? Okay? So, but you got to make sure, though, with that is that you really look around in that area, because what if that patient has a plug, and what if they start coughing? And here comes some secretions, right? They could even cough hard enough to maybe expel that plug out, right? Or even a button. So what are you going to do? How are you going to do that, Ellen? If you need to suction, you can. What else? No, we're just not awake this morning, but that's okay. It's Monday. Okay, so you want to make sure they have a patent airway, absolutely. And make sure, Holly mentioned this earlier, you have to make sure you really look around that cuff, the stoma area where the trach is. You would be amazed on how clean everything looks. And you have the little split gauze, right? And then when you go and you look underneath it, it is gonked. The stoma can be red and inflamed. And just because the outside looks nice and pretty doesn't mean underneath is not. So it is your responsibility as a nurse to go in there and just take a quick peek under there, making sure, because I need to look at that stoma anyways, right? Is it red? Is it inflamed? Is there any drainage? Anything like that. So be very careful, even when they have the plug on it, okay? Because they could have coughed a couple of times and they're okay, but maybe it's trying to seep out around this area. So make sure that you really look at that area, okay? Is everybody good on what a fenestrated is? Okay, so it's just the outer cannula that would have a hole in it. The inner cannula usually does not, and it's allowed for what? What's the purpose of it? So they can what? So they can speak, okay. Okay, indications for why you would have a trach. Okay, we kind of talked about that. Foreign bodies, trauma, accidental or surgical. Okay, maybe they were having a thyroidectomy. Maybe something got nicked, I don't know. Maybe some swelling happened and they can't breathe on their own, okay? So this is kind of like the second best. If it's not gonna be here, this is the second best, okay? Burns, congenital defects, like what? Somebody give me an example of something congenital.
Cleft
I don't know, I'll be honest, I don't know about a cleft palate, but what is something else I talked about last week? Cystic fibrosis. So you may have a patient who has cystic fibrosis that needs a trach, okay, because they aren't able to cough it all the way out. So this might be the only airway means that they have, okay? All right, a little bit more to remove excessive bronchial secretions, like a debilitated patient with severe bronchitis, neuromuscular disease, like what? What kind of neuromuscular problems? Well, it's kind of already there, but that's okay. Let's see if you're reading. I don't know necessarily a stroke. Maybe if they needed one, but what else? It's up there. It's right there. Spinal cord injury, like what? What are some conditions that spinal cord injuries would happen that would require maybe a trach? I'm sorry?
Paralysis.
But like what? Paralysis though, but where? And what are the, they actually have a term for them, depending on, a what? A quadriplegic or a, well, not a paraplegic, but a quadriplegic, or if they had any kind of cervical like problems, not necessarily that they lost all here, but maybe it affected up here. So you have to kind of look at that. Yeah, the paraplegics usually don't, but the quadriplegic, they might, okay? So just make sure that you understand why, because why would a quadriplegic patient need a trach? Because what else is going on? And you know you have some quadriplegic patients that still can use their arms. Not a lot, they're very weak, but you know, but why do you think that they need a trach? What have they lost that y'all take advantage of or take for granted every day? They're what? Okay, but what else? The diaphragm muscles, all of your muscles that you use to breathe, guys, they don't really have that anymore, so they can't necessarily, they can breathe, don't get me wrong, but not with like I kind of call it like a force like we can, okay? So it's a lot harder for them to push that air out, all right? Or maybe to even inhale it in. So they're gonna go and have a trach. All right, some important safety measures I wanna make sure that you guys are aware of. Never remove the trach ties until the new ones are put in, because what could happen? Exactly, and this is why whenever you do checkups, you gotta put the new ones on before you remove the old ones. And I'm gonna tell you, it will happen to you. You'll be like, whatever, I don't have time for this, and I'm just gonna really quickly take those old ones off, and right when you turn to grab the new ones, you look and what happens? I mean, that's when the patient's gonna cough, you know that. And then boop, there it goes, and you're like, oh, geez, really? Okay, so please make sure you put the new ties on, all right? Also, be very careful. Now, I've had to use some scissors to cut the ties before. The Velcro, we don't, but because somebody tied it so tight, but be careful with those cuffs. The last thing you want to do is get those scissors in with that cuff, and then you cut the cuff, guess what? They're gonna have to go and probably do another whole trach again, all right? So be careful with that. All right, so initially a trach may need to be suctioned every 1 to 2 hours. Why? Why at the very beginning? Because what? Why? And what is that called? When the body is trying to get rid of it, it does a what? It's called the what? The what?
It's an immune response.
Yes, but what's it called? Inflammatory response, because the body says you don't belong here, you need to get out, and I'm going to do whatever I have to do to get you out, okay? So they're going to produce a lot of secretions at the beginning. So you might have to get in there every 1 to 2 hours to suction. Check your doctor's orders. A lot of times they'll just say suction as needed. Sometimes they're standing orders. Just check wherever you work, check your policy, all right? But just know at the beginning, they're going to really be producing a lot of mucus, okay? You got to get that out. If you don't, what's going to happen? Well, they're going to they could get an infection, absolutely, but what's the worst thing that can happen if you don't get in there and suction them? It's not the aspiration I'm worried about, because it's already in their lungs. Exactly. So yes, if the longer it sits in there, it could turn to pneumonia. But my main concern is getting that out, because that's interfering with gas exchange, and I want them to breathe. They're going to have problems not breathing with, because of the gas exchange, because they don't have a patent airway before that ends up sitting there and turning to, say, pneumonia, okay? So yes, pneumonia is definitely one thing that can happen, but I want to get in there and suction so they have a patent airway, okay? If y'all had a whole bunch of mucus in your throat and I asked you to just keep it there, Yeah, it's kind of gross. But still, I said, nope, you can't cough that out. You're going to have to wait till somebody comes in there and gets that out, right? So that's kind of how it is for them. So think about that, okay? All right, so I kind of talked about that, of the inflammatory response. And then once the body says, okay, fine, I guess you're going to have to stick around and be with me for a while, so I'll quit making such a fit about it, and it finally kind of calms down. And then you kind of have to see how often your patient needs to be suctioned, sorry. Okay, stabilize the tube during the trach care. What do I mean by stabilize the tube during trach care? What did y'all learn that you're going to do in checkups today? Okay, so you're going to have to make sure when you take that inner cannula out that you stabilize that trach, when you hold onto the neck plate, and that way when you pull it out, because you may have a tendency, and I know these mannequins are like, you know, whatever, but what if you did and you're trying to get it and you just can't get it and then you just pull the whole thing? That's not going to be good, right? And you're like, oh no, what am I going to do? And we'll talk about that in a minute. What are we going to do if that happens? So we really want to make sure that we're stabilizing it. If this is a disposable inner cannula, then guess what? You can just have your clean gloves on and you can hold it, pull it out, toss it, put in a new one. Woo, right? It's nice. But of course for trach, you know, checkoffs, we're going to have to make you use a non-disposable. But again, if you can learn the hard way, I know you can do it the easy way, okay? Okay, and humidified, it is so important, especially for brand new trachs, that they have humidified oxygen, okay? All of you have a built-in humidifier right here. Whether you know it or not, you do, okay? And what does that do for you? It helps moisten. What else does that do? Exactly, because we've got a lot of hair and stuff all in our nasal area, right, to kind of try to capture anything that we may be inhaling, okay? When this is bypassed, you've got to remember that they're going to need humidified oxygen. And how is that going to help with the patient? What about the secretions? Loosen. Why do we want to loosen it? So they can move it out. Absolutely. So if you can move it out, that way it doesn't sit there, gather some more friends, have a party, and turn to pneumonia. Exactly. All right. Because a lot of times that mucus will get really thick, okay, and it'll just sit in there. And if it's not humidified, it just gets thicker and it's harder for them to cough it up. And remember, it's just going to sit there. So we really got to make sure that they've got humidified oxygen. This says long-term scarf. Sometimes I've seen some people that have for a lifetime have a trach. After a while, they don't. It's not like everybody with a trach has to have humidified oxygen after it's been for a long term, okay? So they kind of get used to it, but you may see them sometimes, some of them will put like a light scarf over it that allows them to breathe, but it kind of protects so nothing goes in. So I've seen some patients do that, okay? So I just want to let you know. A little bit more. Okay, new trachs require frequent observation and suctioning. I told you about that, right? Because of the inflammatory response. There you go. All right. It's risk for edema. Okay. And the other thing is that we've got to worry about if it comes out, right? Okay. Do you think you might need a gown, goggles, and mask when you suction a patient? Okay. Why? And how are you going to know if you're going to need that or not?
Maybe they're like gargling a lot. Maybe like they're releasing a lot of secretion.
Okay. But you come in there and you got your whole outfit on. I mean, you look like you're going somewhere. I'm talking, I got my goggles, I got my mask, I got my whole thing, and the patient's like, why do you have all that gear on? Nobody else has done that. I'm sorry? Okay, but this is somebody who's not on contact precautions. Okay, so and ask this in report, okay? Did the patient, are they getting suctioning? Are they producing a lot? There are some that, when you get a report, they're going to tell you they're spewers. I mean, it just comes out, all right? And when, they talk about projectile vomiting, I've seen projectile mucus coming out before, okay? So it's not like they cough and it barely comes here and then it falls, all right? I've seen some that just come out. So if you feel that you need to put on some gear to protect you, that's fine. Also, you might have to maybe do the mask for those of you who mucus is something that really bothers you. Again, you know how we talked about there are some things that really get to us as nurses. Mucus is mine, okay? So I've learned to try to hide my expression. But remember, when you're suctioning that patient, what's that patient doing? They're staring right at you. And if they look at you while you're like, okay, well, thanks a lot, okay? That doesn't make me feel any better as a patient. So be very careful because a lot of times you just don't realize it's all over your face. I've seen it on the faces of students before, and I mean cleaning patients before. And I'm thinking, thank goodness their back is to you because that look on your face, I know, and I get it, we're human, all right? But I really don't want to have to show that to my patient. So if you're the type that you know, I mean, you can go in there and you can hear them, or maybe after the first time you suctioned or you watched respiratory suction, you know how they're gonna be. And if you have to put it on, you have to put it on. I haven't had to put goggles on, but I have had to put a mask on before, and yes, if they're contact, definitely a gown. So it kind of depends on the patient, okay? Couple more safety things. We talked about this. Make sure that you know what emergency equipment is at the bedside. Now, different textbooks say different things, and I will tell you that your Potter and Perry and your Lewis are a little bit different on some numbers, all right? So your Lewis says that the critical time is 5 to 7 days after having a trach, okay? But other books will tell you if it's 72 hours or less. So basically, just know your policy. Please know the policy where you work at on, you know, how long do I need to have emergency equipment at bedside? Because what is this emergency equipment for? In case it comes out, all right. So because if it comes out, how many of you, and I always like to ask this just because of the generation, how many of you have ever had a tongue ring? Or want to admit that you have? Okay, so when you first got it, what did they tell you? If you take that out, is it going to close up really quick? Very quick, okay? So same thing can happen with this. Now, I'm not going to tell you that in 15 seconds it's just going to close up, all right? But it can, like if it comes out, you've got to keep that airway open, and it could start to, you know, close up a little bit. Not that it's going to close completely. And remember, if that closes, then what happens? The patient can't breathe, even though they have all of this. Remember, this is getting completely bypassed, okay? So make sure that you know what you need. A lot of times, especially with new trachs, I have a lot of extra suction kits in the room because that's part of my planning phase in my head, especially if they're on isolation, because I just don't have time to be running back and forth to the supply room. And I like to have everything right there because I never know in the middle of, you know, changing my patient, giving them meds, they may start coughing up some stuff, and I've got my suction right there that I can easily just get it, put it on, and start suctioning as needed, okay? So make sure that you have everything there. Ambu bag, please make sure you don't take the ambu bag that's on the crash cart. Do not take it off of there. If you're gonna have to call some central supply or whoever carries it, then you can say, I need an ambu bag brought up here. But don't just take it upon yourself to take it off the crash cart. And why do I say that? Because, you know, that's when that's going to happen, right? So Jesus took it right off of that crash cart because he's going to go in there and keep it in there because it's a brand new trach. And then sure enough, I have these patient codes. And everyone's going to be like, where is that ambu bag? Well, Jesus took it off, right? So don't take it off of there. And I know it's easily accessible on there, but don't take it off. Please don't do that, okay? All right, some complications. Hemothorax, pneumothorax, which that's what we're going to talk about later on today, subcutaneous or mediastinal emphysema. What is that? We're going to talk about this afternoon too, but I want to see, do you know what that is? I'm used to more of the subcutaneous. What does that mean? What does subcutaneous mean? Air. So where do you think the air is getting into? No, with a subcutaneous emphysema. This is what they call it. Where do you think the air is getting trapped? But where specifically? And where? This can happen with a trach, and it can happen with a chest tube. Okay, so think about you have a trach. Think about you can get some air that gets trapped, like little pockets, all in the tissue right around where the stoma is, okay? If that air gets in there, more air can accumulate. If more air accumulates, what can happen? So it's going to be almost like it's going to look like it's swollen, okay? So you have to assess for that. Have you ever seen that before? Okay, I saw it one time, just one time, and it was years ago, and this patient, not to get off track, but this patient had a chest tube placed, and it wasn't placed correctly, and they did monitor, and he ended up developing subcutaneous emphysema. He said that when he had gone from one facility to the facility that we were at, and he said that he basically looked like he had gained 30 pounds. It had just spread all over up here on him, okay? And so it wasn't causing problems for him to breathe yet here, but he said it was all over here and all in his arms, and he said it did get some on his neck, and it even spread to his face. And we asked him, did it spread down here? And he said no. But what we did do is he said, come and look in my, and it had finally gone down, and the thing with this is there's nothing really that you can do. The body will absorb it. But if it gets in this area and it can cause some swelling, then you're going to have problems with what? Breathing, exactly, okay? So the body absorbs it, and he brought us in there, and we were talking to him about it, and he still had a couple of pockets on his eyeball. I will never forget that. And then the student was doing an assessment, and as she was going to kind of just feel his legs and stuff, she could feel, and we all went in there to go feel, because I'd never felt this before. It felt like, the only thing I could describe it, and I still love it, those little things you can pop, that come in shipping? Yeah, the wrap stuff. And so it felt like those were underneath there. You could just feel it, and I really, I didn't push hard, but it made me want to go, see if those pop, but I didn't do that. But I could just feel, and it was the weirdest thing, and he was like, wow, y'all feel it there, and he felt like, because it never got down below on him. So it's just something that can happen sometimes, so you need to be like just kind of feeling in that area, and you can feel it. They feel like little pockets are in there, all right? And you just don't want it to cause problems with them breathing. All right, so this is something, and we'll talk again about it just very briefly since I've already just, gone over it now, but it's something that can happen, okay? Laryngeal nerve damage, and that can happen as well. Airway obstruction, how can this happen? I mean, didn't we have a trait to have an airway, but how? Okay. Exactly, so it could be clogged with some mucus, it could come out. Infection, what do we mean by infection? Infection where? It could be in the lungs, but infection where else could happen? In the stoma area, absolutely. This is why it's your responsibility to be looking in that area, right? What is this tracheoesophageal fistula? That's a big word. What is that? What do you think it is? Tracheoesophagus, right? Or esophageal, sorry. Ooh, we have an opening between two walls, right? How do you think that can happen? It's the mystery. From the what? From the cuff, absolutely. So this is why they say it's very important with some of these cuffs that you go in there and just check and see, is it being inflated and deflated? Because if it's going to put that pressure on there and we're going to cause some necrosis in there, then it can break down that wall of the trach, and then who's right next door? The esophagus. And guess what? What's that going to do to the patient? Wow, exactly, big time, because now we've got a passageway that goes straight from the esophagus. If we're going to come up, forget it. We're not even going to come this way. Let's just go straight down there. We got another place to go. So think if your patient were to vomit, okay? Or if they were able to eat. Can you imagine? I mean, if they were able to drink or eat anything and it goes down there and some of it's maybe going to the esophagus, so this is something that can happen. This is why it's very important that you check that. We talked about, yes, go ahead.
So sometimes if they have that fistula, rather than getting your secretions through here, it'll be coming out of your fistula.
See?
So just be aware. And typically when people who have the laryngeal cancers and they have radiation, that becomes real friable. So it's a high risk.
So just make sure that you watch your patient. So how are you going to know? We're going to kind of get off the subject a little bit because I want to make sure. What are some signs and symptoms if your patient were aspirating? Are you going to get a text message that they aspirated? No, you're not. I know that you wish that you did, but you're not. So what else?
Teary eyes.
Maybe. Lung sounds. What are you going to probably see change? And it may be the lung sounds. I'm not saying that it's not, because every patient's going to be different, but what else are you going to see start to change? O2 sets, right? And it doesn't have to be like real sudden. It doesn't mean it's going to go from 99 to 70. It could go 99, 95, 93, 90, because the more fluid that builds up in there, the more gas exchange problems that you're having, right? So those are things you need to look at, because I'm like, why would his O2 sats be dropping? I'm looking at that trend, and that's just not making sense, and your patient has a trach, okay? And you could hear their lung sounds, and it could sound just fine, okay? So just make sure that you're doing assessment, and and then what am I going to do about that? Whether the lung sounds are normal or not, if I see that trend going down, what am I going to do? Elevate the head of the bed. What else? If they probably will have some oxygen already, but if they didn't have any oxygen, I can. And what kind of oxygen am I going to give them? I'm sorry? Humidified, but how? What kind? What kind of oxygen? Device.
Oh, like the
Either a mask or an isocannula.
oh, I can't use a nasal cannula. Remember, this is gone. Remember? See, I know, and that's why I asked, because I wanted to make sure that y'all are thinking that you don't go in there when you have a patient whose O2 sats are dropping and you go, oh, let me give you a nasal cannula. Yeah, I don't know what that's going to do for them. The trach collar, absolutely, okay? And then you're going to have to notify the physician, okay? So make sure about that. So do what you can that's within your scope as a nurse, and then call somebody. Get RT in there too. Yes?
So what if you go in there and there's blood all around you?
What are y'all going to do about that? So you got blood all around in here, but the patient's still breathing okay? I'm just asking. I'm trying to see what your scenario is. What do y'all think could be happening with your patient? Maybe. Like, where's that blood coming from? Is the blood from this area, or do they have something else in here that's coming up and they're coughing up blood, but it's coming through here? So you've got to go around and make sure that you're really checking. Is it coming straight out? Is it coming all around the stoma area? You're going to have to clean it up and take a look at it, right? So does that make sense? I mean, you don't think about it, but and brand new trachs, they will probably have drainage, absolutely. And I want to go and make sure that I'm cleaning around it. But you never know. And it could have been that they knocked it or did something that irritated, and then you've got more drainage or blood. Okay, so yeah, see where that's coming from. All right, complications of suctioning. Y'all know this, hypoxemia, cardiac dysrhythmias. Why could that happen? Okay, so you gotta be very careful with the vagal, right? Hypotension, they could cardiac arrest. I mean, hopefully they're not going to do. Atelectasis, lung collapse, mucosal damage. How can you get mucosal damage? From suctioning, absolutely. That's why I don't deep suction. I don't go way deep in there like I've seen some. Okay, when you're suctioning, it can cause them to bronchospasm, right? Okay. Tracheobacterial growth, or tracheobronchial bacterial growth. Some more things there. I just want to show you what an inline catheter is. Okay, I didn't get a chance to show you, but in just a second. And you'll see these used more for ventilator patients. And let me show you why. It's all enclosed. And I'm going to show you a picture because I know you're looking at me going, I don't know what you're talking about. And you follow the same principles as you would for one that's not enclosed, okay? So do you see this picture? Do you see how this part right here, the catheter is inside here. So all you have to do is put on some clean gloves. It's really nice, okay? And then what you do is you just push that catheter out, and this part is connected like if a patient who's on a ventilator, and I could just push it through, okay? And then this over here, it's like a button, but this is connected to the suction. And with this one is if I push the button, that's applying suction. Does that make sense? So it's really nice because I can push it in there, okay, not applying suction, and then hold my button down and then be pulling it out and kind of moving it. Makes sense? It's really nice because then I don't have to worry about maintaining sterile. Another thing, and I didn't want to tell you all this until, well, I should have waited till after your checkup, but oh well. If you don't have an inline like this, majority of your catheter kits, they all have a sheath that covers it. So then you get to put on some clean gloves. So I know that at the facility that I'm at, if the respiratory therapy has to go in suction, it's got an inline, basically not as big as this, but it's just a catheter itself that you connect and it's just closed off. So you just have to wear some clean gloves. You just have to make sure that when you're moving that plastic, you don't touch the inner cannula unless you had sterile gloves on. Does that make sense? So it makes it really nice that they're trying to prevent people not using sterile technique is basically what it is, okay? But I just want to make sure that you could see what this is. So does that make sense? Inline suction, okay? That's just another picture. Patients on the vent right here, okay? All right, so I'm going to throw a case study in here for you, okay? Trying to do a little entertainment here. We've got we're going to call him AM. He's a 45-year-old male who has suffered from a traumatic brain injury 7 days ago. Okay. He's been intubated and mechanically ventilated. Okay, he remains comatose and he's unable to wean from the ventilator at this point. So he's taken to the OR and they insert a number 8 Shiley trach with a non-disposable inner cannula. Okay? Okay. What is your priority assessments when this patient returns back from the OR? I know that a lot of you may not be working in the hospital setting, but I'm still wanting you to know some things to assess for because you're going to go back to school and get your RN. if not more, and you may be taking care of a patient like this. So patient comes back from the OR, has a brand new trach. What are you going to assess? What's your priority assessment? O2 sats, absolutely. What else? Lung sounds, okay. Maintaining a patent airway, what else? Assess the stoma, yes. What else? What is something that you learned earlier this morning? From the lady down there, her name is Holly. Okay, so make sure, because if this patient came back with a trach and he's on a ventilator, correct, then you're gonna have to make sure that if you're in a setting like that, that you check all the settings, make sure that he's getting enough. Look for signs and symptoms of respiratory distress in general, okay? Can this patient even be able to communicate with you? I don't know. He may not when he first gets back because he's still under some sedation. I don't know. They may actually keep him in a comatose. I don't know that. But it's still my job to make sure that my patient is not showing any signs of respiratory depression, correct? Okay. Look for that bleeding too. What emergency equipment should you have available? Spit it out real quick. Okay, the obturator that came with the trach, correct? What else? Another whole kit that's one size or smaller, and maybe an ambu bag there, and what else? Extra trachea suction for sure, okay? Kits are good too, but definitely suction, all right? Okay, what nursing care will you provide that's related to tracheostomy? I mean, I know that we talked about, checking his O2. What are some other things that you want to make sure that you do? And or teach with him?
Communication.
Okay, so communication's really important. Absolutely. What else? Okay, so we don't know if he's being able to eat or not, and he may just, so if he's not eating, because sometimes they may not put a Dobhoff in him or a PEG if it was more long-term in him. So what do you want to make sure he has then? And this gets missed so easy. No. So if my patient comes back and they're not able to eat or drink anything, and maybe they're going to wait to see, they might put in a feeding tube at some point, but in the meantime, he needs what? He needs oral care, but what does he need? Or his kidneys are going to shutting down? Fluids. Make sure he has some IV fluids going. Please make sure, okay? So you've got to check on that, all right? What are some other things that you want to make sure that you do with him to help him breathe better? Holly's mentioned this earlier too. Get that head of the bed up, absolutely, okay? So you want to make sure, so at least 30 degrees, and then do for comfort for your patient, okay? That oral care is so important, okay? I cannot stress that to you enough. Let's just finish with this, guys, and we'll take a break, I know, just because of the videotaping, okay? So hang with me. Trach care, assess your patient's ability to tolerate it, the need for it, like how often are you gonna have to do trach care? Sometimes they won't actually have the patient, to take out the inner cannon and do trach care until a certain amount of time. It just depends on the facility policy and if the doctor ordered anything. Sometimes they have standing orders, okay? Precautions to prevent, so replacement of the tubes at bedside. And this just came from your Lewis book, but check your policy. A lot of times they do not want you to change those ties for the first 24 hours, okay? And then also your book says that a physician, or it should be a healthcare provider, usually performs the first tube change. Check where you are. Some do, some don't. It kind of depends on where you are. This is just what your book is just saying, okay? Complications. All right, so here's my complication questions to you. You walk in a patient's room who is 2 days post-op from having a trach, and you walk in there and they're having some respiratory distress, and you look and you're like, where's that trach? And you don't see it there, okay? What are you going to do? Okay, well, I've got my emergency equipment at bedside. What are you going to do? Okay, if you see the trach that came out, maybe it's just laying like here. Okay, that's great. Perfect. I can get it. I can get my obturator if I need to. And if you want, I mean, really and truly, guys, I would be calling for help just to make sure, because I don't know what's going to happen with my patient afterwards, but I'm going to go ahead and call for help. So if I have to, I've got to maintain a patent airway. Now, let's say you go in there and you can't get this at all back in, and you're like, and you don't want to like cram it, right? At all. So what can you do also? Do y'all know? Yeah, that's not working either. Yeah, she said to put the mask on, okay? But I really would like to try to keep this open. This is where you kind of have to use some like MacGyver moves here. I mean, you really do kind of think about it. What else could you do to try to keep this open? Okay, exactly. And sometimes, now your book even talks about this, it says that if you had to, you could get some hemostats to open it up if you needed to, and at least have something. Just remember, something is better than nothing. Just at least put this back in the inner cannula so you have something to, keep it open. Absolutely, okay? So you want to make sure. Let's just say nothing is going to get there. Nothing at all. I mean, for some reason, I don't know, maybe you got report, maybe that nurse never checked on that patient, maybe they're in a lot of respiratory distress, and I mean, you're calling a code team to come in, and it's so tiny, you can barely even get anything there. What are you gonna do? What do you think, guys? Well, I've already called the code team, absolutely, but when the code team comes in, how are we going to give this patient oxygen? How are we gonna resuscitate this patient? We have the tiniest of all tiniest little holes now right there. I'm just giving you a scenario. What are you gonna do? Okay, you might be able to, but remember, it's gonna be really, really small. What else do you think you could do if you absolutely had to? I'm sorry? No?
You could cut the part of the suction tubing.
But now, do you know how small that suction tubing is? Okay, and if the code team's gonna come in, they cannot put an ambu bag over that tiny little suction. No? Think of it this way, if worst case, and you have to, then they're gonna have to get something where they can completely cover this up and put the ambu bag on him this way. Does that make sense? If that's the only way, because if it is so small, I mean, think about it this way. I would like to keep it open, but if an ambu bag's gonna have to be applied, if you think about the ambu bag is not gonna fit over a catheter. It's so small. Y'all know how small the catheters are, correct? Okay, so they can pump them. Where's it gonna go? Just out here. It's gonna go around it, all right? So if it's just too small, and think that's like y'all having a hard time breathing and I give you a straw to breathe out of. That's really hard, right? So if you have to, you're gonna have to find something that you can completely cover it, and you're gonna have to put that ambu bag over here and make sure that this is covered, because if you don't and you put the ambu bag on this and you give them oxygen, what's gonna happen? It's gonna come out this way, correct? Okay, so that could happen, but I'm giving you some scenarios. That's why I said it's kind of like a MacGyver move. Okay, so I know I said that we're bypassing this, but if this is really, really tiny, and I don't think they're gonna be able to get enough air, and I don't know how I'm gonna get an ambu bag even over that, then I'm gonna have to figure out something to cover and go here, all right? All right, so I kind of already talked about all that fun stuff. We're gonna keep on going. Okay, communication is really, really important, all right? Sign languages are good. I'm great at charades, okay? Maybe the patient isn't, but I'm really good. I think I'm good. I'm really not, but I think I am. So figure out a way to communicate with your patient. I can't imagine being in their situation that I can't speak and I can't get my needs known to the staff on what's going on. It could be something as simple as, I'm really uncomfortable in my position, but how am I gonna say that? And I've got wires and things all hooked up to me if I'm in like an ICU setting and I can't really move all that, or what if I can't even move? So you've got to figure out, what if the patient can't even, what if they are paralyzed from the neck down? How else are you going to be able to communicate with them? They can't write on stuff. They can't do sign languages. They can't do a thumbs up. What are you going to do? Huh? Blinking, but what are you going to do for blinking? Like, do you do Morse code blinking? I'm not sure. What do you mean? Okay, so yes and no, something like that, and so the questions you ask need to be the yes and no answer, not open-ended, right? Because that's hard for them. So you've got to make sure, because that's going to reduce a lot of anxiety with them. It really is, okay? And remember, they can still hear you just fine. So just because they're not speaking doesn't mean they can't hear you. Be very careful what you say around them. Okay, documentation, this is going to be up here. We're not going to get into that because this is something that you're going to do whenever you get into the skills lab. But basically, you're going to document everything that you did. Okay, short and sweet, to the point. Because I want to kind of keep on going. What are some ongoing tracheostomy care that you're going to do? Initially, they're going to have some unified oxygen, right? Okay. Let's see, tubes should be changed out monthly. Kind of just depends on the patient and the doctor and what they want to do. Patient can be taught how to change the tube at home, and they use clean techniques, so there's no sterile, all right? Even with the suctioning, if they were to need to suction, they're not gonna use sterile. Got to monitor for the complications. Let me make sure. We talked about all the different complications. This is an example of somebody who's at home who's actually changing out their whole inner cannula, okay? So she doesn't have any gloves on, and they probably aren't gonna have any gloves. So what are you gonna teach them to make sure that they do? Wash your hands. Please make sure that you tell them to wash their hands, okay? Because anything that can go in there, I don't want to have to worry about them coming in with some kind of infection, okay? All right, we're almost done. Speaking valves, all right? They're called the passive valves is what I'm used to, all right? So it's just, I'm going to put all this up here so then we can talk about it. Okay, so they come in different sizes depending on the patient. This is another way that they want to allow the patient to start speaking and another way that they want to see if the patient can start to be weaned. So they're going to start off with a bigger size maybe, and what it does is allows for the air to come in, but not the air to come out this way, so the air will go up so they can speak. Yes, so they can speak, okay? And then what they'll do is respiratory will come in and they'll start going smaller and smaller as far as the sizes until they get to where it's almost like the button or the plug, it's kind of what I call it, and then everything, they're breathing everything up here, okay? So if you can talk to respiratory when they're going in there, and a lot of times you'll see these and they'll put them in for so many hours and then they'll take it off. And they'll be in these little, they kind of make me think of the denture cups containers, all right? So be careful that you don't throw that away, because RT will usually leave it in the room right there, so that way they can put it on there. So if RT were to go in there, and this is the first time an RT puts on a passy speaking valve on them, what is your responsibility afterwards? Because RT's got a lot of patients to see. What are you gonna do? This is the same thing that we talked about earlier with a plug or a button, guys. Same thing. Okay, so they would be able to inhale, okay, because remember I told you it's like a one-way valve. But exhale should come through here, but it doesn't matter. You still want to make sure that they have a patent airway. What else are you going to do? What are you going to tell your patient, teach them about? Because I don't know, maybe I got an RT person who just went in there and put it on there and left and didn't even tell them what it was for. Okay, and what else? Because I want to make sure that patient can communicate with me and let me know if. Yes, absolutely. So they could put it on, and at the very beginning, the patient's fine, but then later on, maybe they are having a hard time breathing. I don't know. And I'm not going to get a text message that they're having a hard time breathing, correct? You've got to make sure that you have your patient involved in their care. Tell your patient, you call me if you start feeling this. At any time you call me, because that's how I'm going to know. Because if I happen to not be in that room, how else am I going to find out? Even if it's just a little bit, let me know. What if, now here's the other thing. You've got the passies. So what if the patient starts coughing up and all these secretions? Remember, it's not going to come through here. So what are you going to do? You walk in the patient's room, boy, you can hear all that stuff in there. They've been coughing up some good stuff, okay? And they're not able to maybe get it through here, okay? And remember, this is a one-way, so air can go in, but nothing comes out. So what are you going to do? You're going to have to take it off, and you're going to have to blow in it. What are you going to do? Suction it, okay. Let's just suction it, okay? So you might have to. So don't be going, oh, but I don't know if I can take that off. Well, if your patient can't breathe, you better go take that off, and you better get a suction and get in there and suction, right? And then if you need to put it back on, you can, or you can talk to RT. Remember, like Holly said, RT is your best friend when it comes to all this respiratory, okay? Are we good? All right. All right, so we've got Mr. AM, and he's improving, okay? And so now he's been taken off the ventilator for 2 weeks, and he's ready to have his trach removed. Yay, we're so excited for him. We're going to have a little decannulation party for him. That's what we're going to call it. All right. So what will you assess prior to removing the trach? Lung sounds. O2 sats. Okay, so he still has the trach. Remember that. So they haven't taken it out yet. And hopefully they've got a button or they've got the passy, okay? And they've got it down to the smallest size. So before they take it out, you better make sure what? Okay, that you have doctor's orders, and what else though? That they can breathe, absolutely, because maybe somewhere something got lost in translation. I don't know. So if I got an order that says that, it's time to take it out, but the patient's still having a hard time breathing, on their own, what am I going to do about that? Just take it out and cross my fingers? Yeah, no? Okay, so I'm gonna have to get in touch with the healthcare provider and say, hey, I just wanna let you know they're still really having a hard time breathing, so maybe we need to keep it in a little bit longer. So make sure you communicate with them about that, okay? And how will you care for the stoma after the trach is removed? So they come in, and respiratory might be the ones that take it out. Just find out what the policy is on who takes it out. So they end up taking the whole trach out, and then what are they gonna do? What do you think you're gonna do with that stoma area? I'm sorry?
Maybe sew it up.
No, I don't sew it. I can't even sew a button.
I'm just saying. Will it be sewed at some point?
Not necessarily. They don't usually sew it. I want to clean, and kind of depends on the trach and the size. Holly, I don't know if you've seen, like I've seen them go in and kind of like either get like it's not a pressure dressing, but it kind of is, and they'll try to get it to where the hole was, it kind of goes more like flat. And so that way they'll put the dressing on over it, but still the hole may not be all the way flat. So whenever you put on there, I've watched patients before, and it makes me think of a frog, because when they exhale, there's still juice, but it kind of goes whoop, and it kind of does that. Okay, so just make sure, I mean, we need it covered, okay, because they should be breathing on their own through here, correct? But sometimes I've had it do that, and then what happens is then it ends up coming off. And then they can get what else in this area? That makes all the tape and stuff start coming off. Mucus, right? Because remember, they're coughing it up, but maybe again, if the mucus is coming this way, if they see a door, they're going through there, they're not going to keep on traveling up. So it's going to come through there. So you're going to have to make sure, you might have to change that quite often. Okay, so just make sure you really want to secure it, and then we'll talk about, hang on, how long it takes for it to end up closing up. How long do you think it takes usually to close up? Maybe a week. The book says 4 to 5 days, so it just varies, okay? But you have to still go in there and even just take a look around it, okay? And then even check on your patient. Are they still able to breathe even though they did the decannulation? But it's amazing how much of that, when they're coughing stuff up, that mucus gets in there, and then their dressing comes off, and then you walk in the beginning or middle of your shift, and then it's just a hole. Okay, I gotta go cover it, right? Because they got decannulated, and I need to cover that because I don't want anything going in, because that prevents what? No, I don't want anything going in that hole. And I don't want anything to aspirate or have any kind of foreign object, or, I don't know. Maybe they're using a pin to scratch. We don't want to draw, something. Okay, and then I don't want to worry about infection either, correct? Okay, so make sure that that dressing's on there really good. So clean that stoma. You may have to change the dressing periodically and get a new one to put on there. Tell the patient that a lot of times if they are going to cough, they may have to splint. Does that make sense? And I've seen them, they'll get a good cough and boop, there it goes. And I just tell my patient, call me if that happens. I've got to come back in and put another dressing on them. Closes in 4 to 5 days. Skills lab, we're going to do that. Any questions on trach? I know that was long, I'm sorry, just for the video time thing. Any questions? No? Y'all know everything there is to know about a trach. Okay. Okay, so let's break.